Recording in progress.
Welcome and thank you for joining us today for Sisters Network, Inc., the State of Black Breast Cancer Crisis, a national town hall discussion and call to action. I hope you enjoyed the welcome messages from Karen E. Jackson, Reverend Al Sharpton, and Congresswoman Sheila Jackson Lee. I'm Athena Jones from CNN, and I'm proud to be your moderator for this historic event. This important discussion means a lot to me personally because I am a 5-year breast cancer survivor myself. I was diagnosed at 36 because my doctor happened to believe in doing what she called a baseline mammogram at that age. It was a good thing since breast cancer was not on my radar at all, and I was not aware of any family history of the disease. I'm looking forward to hearing more about what we can do to save more of our sisters' lives today. We're so excited that you have made your breast health a top priority today, and that we have over 1,450 people from around the country who have registered for this important discussion about the Black breast cancer crisis. Sisters Network, Inc. has invited several esteemed medical experts, elected officials, and national leaders that you will hear from during this town hall. A special thank you to our national title sponsor, Pfizer, and other sponsors, Genentech, MD Anderson Cancer Center, Merck, and Quest Diagnostics, our national technology sponsor. We also have some wonderful national strategic partners, the Links Incorporated, Sigma Gamma Rho Sorority Incorporated, Top Ladies of Distinction Incorporated, Black Health Matters, Breast Cancer Wellness Magazine, the National Alumni Association of Spelman College, Howard University Alumni Association, Texas Southern University Alumni Association, and Brothers Helping Sisters. I do want to mention that Congresswoman Sheila Jackson Lee was scheduled to attend, but was not able to make it. Of course, we saw her opening message in that video, her welcome message. Before I introduce our first panel, I think it's important to share some breast cancer facts and figures as it relates to Black women, the topic of our discussion today. Now, I'm not going to read all of these figures. There are quite a few, but the numbers are startling. Breast cancer is the most common cancer among Black women. Black women fear a cancer diagnosis and often avoid screening. The 5-year survival rate for Black women is 81%. It's 91% for white women. Black women under 35 get breast cancer at 2 times the rate of white women and die at 3 times the rate. And Black women have 2.3 times higher odds of being diagnosed with triple negative breast cancer. So those are just some of the important facts on that slide. And I hope these figures help you understand why Sisters Network is sounding the alarm that there is a Black breast cancer crisis. So let's talk about the state of Black breast cancer. I'd like to briefly introduce our panel. They'll share their perspective and then we'll have an open discussion. First, Karen Eubanks Jackson, founder and CEO of Sisters Network, Inc., is a 28-year and 4-time breast cancer survivor. Jackson is author of In the Company of My Sisters, My Story, My Truth, and recognized nationally as a visionary and leader in the Black breast cancer movement. Founded in 1994 by Jackson, Sisters Network is the oldest, largest, and the only national Black breast cancer survivorship organization. The organization provides national educational outreach programs, survivor support, financial assistance to thousands of breast cancer survivors annually, and support through over 25 survivor-run affiliate chapters nationwide. Nearly 3 decades ago, Jackson founded Sisters Network during her own personal fight to survive breast cancer. During that time, Jackson recognized a lack of sisterhood in many of the breast cancer organizations, a staggering mortality rate for Black women, and limited culturally sensitive breast health material. Often regarded or often referred to as a breast cancer champion, Jackson's primary motivation was to break through the silence and shame of breast cancer that immobilizes many Black women, restricts their ability to receive support services, interferes with early detection, and ultimately resulted in them losing their lives. So a leader and a visionary, Karen E. Jackson continues to try make a difference every day and is committed to Sisters Network Inc.'s national creed. In unity, there is strength. In strength, there is power. In power, there is change. We also have Dr. Edith P. Mitchell, she's board certified in internal medicine and medical oncology, and is a clinical professor in the Department of Medicine and Medical Oncology at Sidney Kimmel Medical College at Thomas Jefferson University, and Associate Director for Diversity Programs and Director of the Center to Eliminate Cancer Disparities for Sidney Kimmel Cancer Center at Thomas Jefferson University. She is also a retired Brigadier General, the first woman physician ever promoted to that rank in the Air Force. Dr. Mitchell has spent her medical career helping individuals in medically underserved areas to realize that simple changes in lifestyle can have a dramatic impact on cancer care. Dr. Mitchell's research in breast, colorectal, and pancreatic cancers and other GI malignancies involves new drug evaluation and chemotherapy, development of new therapeutic regimens, chemoradiation strategies for combined modality therapy, patient selection criteria, and supportive care for patients with gastrointestinal cancer. Dr. Mitchell served as the 116th president of the National Medical Association. Because of her experience in the cancer research community, Dr. Mitchell served as a member of the NCI's Blue Ribbon Panel convened to advise the National Cancer Advisory Board on then Vice President Biden's National Cancer Moonshot Initiative. In 2019, Dr. Mitchell began service as a member of the President's Cancer Panel, and in 2020, she became a fellow of the Royal College of Physicians. We also have Dr. Lisa Newman. She's a surgical oncologist with a practice dedicated to breast cancer management. Dr. Newman oversees the breast program for the Weill Cornell Medicine New York Presbyterian Hospital Network. Previously, she worked at the Henry Ford Health System, where she served as breast program director, covering multiple hospitals throughout Michigan. She's also the founding medical director for the International Study of Breast Cancer Subtypes. Dr. Newman was professor of surgery and director of the Breast Cancer Center for the University of Michigan in Ann Arbor, where she also served as program director for the Breast Fellowship. Dr. Newman currently serves as chief national medical advisor for the Sisters Network Inc. Dr. Newman's primary research has focused on race and ethnicity-related variation in breast cancer risk and outcome, the evaluation and management of high-risk patients, broadened applications for neoadjuvant chemotherapy, and special surgical techniques such as skin-sparing mastectomy and lymphatic mapping sentinel node biopsy. Her extensive research related to disparities in breast cancer risk and outcome has been published in numerous peer-reviewed medical journals and was featured in CNN's documentary Black in America Too. She also oversees an international breast cancer research and training program involving a network of physicians and facilities. The program is focused on the study of triple-negative breast cancer in women with African ancestry. I should mention that Dr. Newman has also been incredibly helpful to me as I explore this issue in a documentary I'm working on focused on Black women and breast cancer, particularly young Black women, and the issue of screening guidelines. So that is our brief introduction of our panelists. Thank you to all of them. As we begin this session, we're going to hear first from Karen E. Jackson, the founder and CEO of Sisters Network. Each is going to give brief remarks before we open up the panel discussion.
Good morning, everyone. Thank you, Athena, and congratulations for your 5-year mark. That's significant. Today is very historic day for Sisters Network as we lay the foundation to take action on the Black breast cancer crisis. As Athena mentioned, I am a 28-year, 4-time breast cancer survivor. That Sisters Network and I are very excited that we have been able to go through 3 decades of awareness, education, research, but that is not enough. Sisters, as a leader in the National Black Breast Cancer Movement, recognizes it's time for us to advocate for changes to policies, to revisit medical guidelines for baseline screening. We cannot do this alone. We are grateful for our amazing medical experts that were listed, the elected officials that have come on board, the national thought leaders and to our sponsors and our strategic partners who showed up to recognize that the importance of joining together to change the narrative that Black breast cancer is a crisis. More importantly, the new initiative on the National Black Breast Cancer Health Equity Policy and Community Action Task Force plans will be shared during the conference. We thank all of you for joining us today. As I said, this is historic, so mark your calendar. We are excited to have everyone on board. Thank you, Athena.
Wonderful. Thank you, Karen Jackson. And now Dr. Edith Mitchell will give brief remarks.
Thank you so much, Athena. Thank you for being here. Thank you for your survivorship in breast cancer. And thank you, Karen Jackson. Ms. Jackson, you and I have worked together many, many years in many different aspects. And it is so important that we all come together. So Karen, thank you so much for your organization of Sisters Network and the propulsion of the idea that people need to talk, get information, and therefore have better access to medical care. As a member of the President's Cancer Panel, one of our goals is to advise the President of the United States on where are the gaps in service, the gaps in care, so that we can decrease that gap, as you mentioned, Athena, between the survivorship of Black women with breast cancer and white women as data are collected. Data has been collected since 1975, following the National Cancer Act in 1971, signed by then former President Nixon. And since that time, this is 2021. So we've had 50 years of the National Cancer Act and therefore research in cancer. And data shows that although the mortality rates for breast cancer have decreased and we've had great research, great information, still the gap between Black and white patients' survival is still there. And it at sometimes has even increased as we have found more research. So there are a number of factors. Number one, insurance. Black women do not have equality in insurance coverage for either screening or diagnostic procedures or in treatment. So there is already a gap. Another area of research, we don't have enough Black doctors in our communities helping us and intervening with us and for us. There have been a number of factors that have decreased the number of Black doctors in this country. The 1910 report, the Flexner report, was supposed to revive medical care or medical education in this country. And it is still the white paper on medical education. But what the Flexner report did was eliminate all of the Black medical schools in this country except 2. So 7 schools were eliminated, which meant that Black individuals who wanted to go to medical school had no auspices to do so. And that decreased the number of Black doctors. The other majority schools did not increase their enrollment of Blacks in medical school until forced by the former President Johnson's Great Society, which included funding for medical schools. So therefore, we are approximately 13% Black Americans in this country, yet the practicing clinicians only less than 5%. And we know that Black doctors usually, and in many cases, return to their communities. So we've got few advocates for us in the community. There's the history of redlining, which means that Blacks live in a certain area of the cities and don't have access to healthcare, access to mammograms, healthcare centers, and individuals to advocate for us. So we've got a lot of factors that we've got to worry about. Then there is the COVID. Since the pandemic, about 20 months ago, the incidence of screening for breast cancer, as well as other cancers, has decreased significantly. So the American Cancer Society estimates that in 2 to 3 years, we're going to see these death rates go up again. So we've got to really collaborate, bring all of our resources together so that we are fighting breast cancer. We know that it has a much greater mortality rate, especially with triple negative breast cancer. So all of our resources need to come together. So
Wonderful.
Thank you.
Yes, thank you, Dr. Mitchell. This is what the reason for this call to action. We know the problem is multifactorial. And now Dr. Lisa Newman is going to make some comments. Dr. Newman.
Thank you so much. I'm so proud to be a part of this incredibly esteemed panel this morning. Edith, what can I say? I applaud you for all that you're doing, leveraging your influence nationally and with the federal legislation to make sure that there are resources to support all of the work that needs to be done. I thank you from the bottom of my heart. And of course, I thank you for your friendship over the many years that we've known each other. You're just a national treasure. And Karen, what can I say? We've known each other decades now. You are just as fabulous and incredible as the first day that I met you. And thank you for everything that you do in making sure that the advocates' voices and the advocates among African American women with breast cancer, that the voices are heard and remain influential. Athena, you showed some incredibly powerful statistics before. I thank you for using your incredibly powerful voice and your resources with the media to promote messages about breast health awareness and how important it is in the African American community. In all of those statistics that you showed, demonstrating the disproportionately high mortality rates from breast cancer in African American women, the more common late stage of diagnosis, as Edith mentioned as well, we all underscore the fact that there are atrociously higher rates of poverty and lacking medical insurance in the African American community that contribute to these statistics, resulting in delays in treatment, delays in comprehensive management of the breast cancer. And unfortunately, the systemic racism that exists throughout our society influences public health, and it does result in Black women receiving less equitable care. We have so many things to combat when it comes to the social determinants of health and how these social determinants of health disproportionately affect the breast cancer burden of African American women. But it's not all about the socioeconomics. As everyone has alluded to already this morning, there are higher rates of the biologically aggressive triple negative breast cancer among African American women. African American women are more likely to get breast cancer at younger ages, and we have higher rates of male breast cancer in the African American community. So we have a lot of research that needs to be done to better understand the tumor biology and genetics that account for these differences in the burden of breast cancer in African American women. The lack of data and the lack of information regarding the explanations for these issues, I think, is related to the issue that Edith mentioned. There is a lack of diversity in the research, the oncology research community, and we are going to have the strongest motivation to get this research done properly and to make sure that we understand all of the causes of breast cancer disparities, including issues related to tumor biology and genetics. Lacking that diversity in the healthcare workforce, hearing the voices of the is even more important. We need the breast cancer patients from the Black African American community to continue speaking out and driving to the oncology research community, driving it into them, the importance of getting this research done. So again, I come right back around to you, Karen, and thank you, salute you for making sure that your voices are heard continuously.
Wonderful. Thank you, Dr. Newman. And now we have several sort of a Q&A session, and I want to make sure we cover as much ground as we can. So if it's okay, I'm going to direct these questions towards one or two of you at a time and hope that we can get as many questions in as possible. So let's start with Karen E. Jackson, who can talk to us a little bit more about why this event is so important. The whole purpose of this event, examining the state of Black breast cancer.
As I mentioned, our Sisters Network wanted to make sure that we change the narrative that breast cancer for Black women is a crisis. So in that thought, we know that it's time for the policies and time to redirect some of the guidelines. So bringing the thought leaders together today and taking it to the future in 2022 with our task force, which is why this is such an important historic moment in the breast cancer movement, that we can change some of the outcomes by all working together and finding the results and making things happen. That's who we are. That's why we're here. And we thank everyone for participating and continue to participate.
Wonderful. And it's so important that this be a broad and wide collective effort, reducing disparities. Health disparities, as we've laid out, are a real problem. So how should Black women advocate for themselves to ensure they get the best care? Perhaps Dr. Mitchell or Dr. Newman or both of you could weigh in on that idea.
So thank you so much, Athena, for that question. And certainly there are measures that all can take. First of all, women need to advocate for themselves. For example, like you developing breast cancer very early before you even had a standard mammogram. Many women who are young, and Black women develop breast cancer at a much younger age than others. Women feel a nodule in their breast. They go to their doctor and the doctor says, you're too young to have breast cancer. What that woman needs to do then is go find another doctor, get another opinion. Second opinions are very important. My youngest patient with breast cancer was 19 and was told, oh, you're too young. It's just a little benign thing. And she had significant stage 3 breast cancer. So we need to advocate for ourselves. We need to find resources. In most states, the CDC, the Centers for Disease Control, have screening programs both for cervical cancer and breast cancer. And many women don't know about that if they're in a certain economic category, they can get a free mammogram covered by the state through the CDC. Many women know that. The Black community doesn't know that. So we need to advocate for that. It's also recognized that in states that have, through the ACA, have Medicaid expansion, those states now show that there is a decrease in mortality rates. There is a decrease in the delay experienced by many. In many cases, Black women take 5 months to get finished with diagnostic procedures so that they can get treatment. That's much too long. And the next thing is find a center that specializes in breast cancer. The National Cancer Institute has made available programs throughout the country, every state and in most localities. So find a practice that is a part of the National Cancer Institute's network. There are over 1,100 throughout the country. So we've got to find the information, get the information, utilize it and find those resources that can advocate for us.
Dr. Newman, do you have anything to add to that? I mean, Dr. Mitchell laid
Yes.
out a lot of good points there.
Yeah. As always, Edith
As always.
told it just as it needs to be said, and I certainly agree for all her points regarding advocating for yourself. And I want to just put out there a comment about screening mammograms. Please, average risk women need to start their yearly mammograms at the age of 40. There's a lot of controversy out there regarding the age at which women should start getting those mammograms, with many saying that women should wait until they reach the age of 50. Please,
Yeah.
at age 40 and get them every year. This is especially of critical importance in the African-American community, because as Black women, we are at risk for getting breast cancer at even younger ages. So they have to start at age 40. But mammograms are not perfect. If you have a danger sign of breast cancer, a new lump in the breast, lump in the underarm, bloody nipple discharge, change in the skin appearance of your breast, please see your doctor and get checked out. And as Edith said, if you're not getting adequate answers, seek another opinion. Somebody I noticed put a comment in the chat room about how do you get that second opinion when you have so much trouble getting the first opinion. That's a tragedy. It is horrendous that we have to place this burden of working so hard to get appropriately evaluated on the shoulders of a woman. But unfortunately, that is where we stand today. And we do have to keep impressing upon women the importance of fighting to advocate for yourself. Please, when it comes to advocating for yourself, also advocate for on the part of the community by getting rid of some of the myths that are still perpetrated out there and that results in unnecessary deaths. A breast biopsy is not going to make a cancer spread. A cancer spreads by being delayed in its diagnosis or being delayed in its treatment or not being treated at all. If you have an abnormality in your breast that needs to be evaluated and you need a biopsy, please get that biopsy done so you can get proper treatment.
Absolutely. And Athena, I would
Yeah.
like to add that the National Cancer Institute, I said 50 years of cancer research since 1971. We have over 1,100 sites throughout the country, and you can find those by going onto the NCI website and find one. You may find that it's right there in your community that is available. Also, we recognize that mammograms are not perfect, and some individuals may need other diagnostic tests and procedures done. There is also, sponsored by the NCI, a TMIST, it's TMIST study ongoing now, where we can find out some information regarding breast cancer and the availability and the use of mammograms. So we know that mammograms are not perfect. However, we've got research ongoing, and we should take advantage of those opportunities to learn more about mammograms and other diagnostic procedures, as well as tissue, so that we can understand some of the causes of the disparities that exist among women with breast cancer. And also, as Lisa mentioned, with men, Black men have higher incidence rates of breast cancer than white men. And again, more aggressive features. So we've got to take care of the men as well.
I'd like to add,
Absolutely.
Athena,
Of course.
that support organizations, that's one of our major roles, is to help navigate the newly diagnosed through the system, because the system is awesome, the information is there, but we are able to support you to learn what avenues are best suited for you as a newly diagnosed survivor. And having that support and the sisterhood helps you have a better journey of your breast cancer.
Absolutely. Support is so important. And each of you has raised an important point in one way or another. I think particularly when it comes to examining your body, if you find something, you go to the doctor says, oh, you're too young. really moving on to someone else who can make sure that there's nothing to worry about, because I
To
know
advocate on your
personally
behalf.
of people who have run into much bigger problems because they didn't really follow up because a doctor kind of dismissed it. So lots to cover here. We have about 15 more minutes in this session, but only a few more questions. And I'd like to hear from all of you on these questions. And something Dr. Mitchell said leads perfectly into this question, which is about screening. Do you all think it is time to revisit the current breast health screening guidelines, whether it's mammograms or ultrasounds? And a related question is this idea of dense breasts and the challenges they present. The patient I mentioned who, people who may go in and think something's just a cyst when actually it ends up being a tumor. Talk about the challenges of screening dense breasts and whether that should mean more ultrasounds. So screening issues and guidelines. Who wants to go first? Dr. Newman?
Sure, thank you. It is true, Athena, as you mentioned, that women with dense breasts do have more challenges in terms of their mammograms being accurately interpreted. And I encourage all of you to tune in to Dr. Mosley's presentation later on today. And Tanya, as a breast radiology expert, has also put into the chat box important information regarding the TMIS trial that Dr. Mitchell mentioned. Very, very important study to improve breast cancer screening in the future. Now, back to the dense breast issue. Breast density in the terms of it being a risk factor for future breast cancer, which it is something that needs to be defined by the mammogram appearance. Your doctor examining you and saying that you have a lot of fibrocystic changes or dense breast tissue, that is not breast density that indicates higher risk for getting breast cancer in the future. But mammographic patterns indicating very thick breast tissue is a risk factor for future breast cancer. And women that have dense breasts on the mammogram will indeed often need supplementary imaging, usually in the form of breast ultrasound, to help the radiologist in interpreting that breast density and to help the radiologist in detecting breast cancers at even earlier stages. And often women will be recommended to have additional imaging such as breast MRI if they are found to be truly at higher risk for getting breast cancer in the future. So there are several different options to better evaluate women as adjuncts to mammography. We absolutely advocate in favor of women exploring all of these avenues. I do echo Edith's comments about the importance of research. And if you are diagnosed with breast cancer, please do advocate in favor of participating in clinical research, because that is the only way that we are going to get answers to so many of these questions that have been posed. And participating in research doesn't necessarily even mean that you're committing to a clinical trial that will affect your treatment. Sometimes contributing to research means participating in a database or a biorepository where you're simply sharing information about yourself with researchers. And that can be incredibly powerful in learning about the burden of breast cancer in the Black African-American community.
Certainly research is such an important aspect of this. Dr. Mitchell or Karen Jackson, would you like to weigh in on this discussion about whether guidelines, particularly for Black women who we know get breast cancer at a younger age, should they be adjusted?
This is why the task force is very much needed. At this point, we know there's so many women who are slipping through the cracks with all that is available to us. But first and foremost, your knowledge is important. You will need assistance to understand the knowledge that you are gaining. And with your knowledge, you'll be able to say to a doctor who says, don't worry, then you know you have to get a second opinion. With your knowledge, if the doctor says, don't worry, you know that you can ask for an ultrasound because you feel something in your breast or you're concerned. Knowledge is power. That is not a slogan. It can save your life. And this is why we are here today. So much is going on in that industry of breast cancer. We need to solve some of these mysteries.
So Athena, regarding the guidelines, we recognize that there are some differences in guidelines. For example, from the American Cancer Society, the National Cancer Institute, the NCCN. So there are some differences. And a part of what the President's Cancer Panel is doing is bringing together individuals from these various societies that have guidelines to try to bring them all together. Because what some clinicians will say is that, well, this one says that, and the American Cancer Society says something else. Who are you to believe? And it's not so much as figuring out which one you want to believe, but following some guidelines, following some recommendations so that we are following some pattern. But the most important thing, first mammogram by age 40, and therefore follow up. But as we have mentioned, there are differences in women's breast. We used to think breast cancer was one disease. Breast cancer is every woman's disease, so that for every woman, there are differences, both in terms of the diagnostic procedures, and in most cases, MRIs are approved for use in women with dense breasts if needed, but not all insurances will agree to that. Not all insurances will approve of the MRI. So you've got to have advocates in that arena as well. But the important thing is for women to get answers to their questions, get the answers, and therefore advocate for yourselves so that we can fight all of these obstacles. And in many states, MRIs are approved for coverage, but not all states. So we've got to have our health policy experts, our representatives, and we've got to communicate with them well. So we need to look at our states individually regarding coverage for screening, coverage for diagnostic breast examinations, and therefore indicate when we need to, and speak with your representatives. I can tell you that my representatives from Pennsylvania, if I call, they know who I am because I'm going to be saying something for them. And once you get that information with your state representatives and your Congress, they will advocate with you and for you so that the representative from my district in the US Congress knows who I am, and he's been out there advocating for women. So we can't forget about health policy and talking to the people who represent us in these areas.
And I think this is an important part of the goal here of this task force, if I'm right, Mrs. Jackson. So
Correct.
we only have a few more minutes. I'm going to try to combine. I had a question about what the medical community can do differently, but I think just as important is the role that cultural norms are playing in all of this, in Black women's breast cancer outcomes, and how fear and silence, I mean, do we see that as a major factor? So it's kind of a combined question, but perhaps you can go first, Karen Jackson, and talk about either what the medical community can do differently or the impact fear and silence and shame and these issues play on Black women getting screened and getting care for their cancer.
Well, first and foremost, the fear that our community has of screening and of being diagnosed does hinder the woman from going forward. And as an organization, we say you should fear not getting a test or participating in the mammogram, because that is going to harm you, not the fear of what's going to happen, but not finding the cancer. So we try to change that mindset to do what you have to do, even though you may fear what may happen, and you could find it early so you can live. And that's our message to the community.
And does one of the other doctors want to weigh in right before we wrap up this session?
So education of the healthcare community is
Mhm.
also important.
Mm.
I mentioned that there are various societies, various organizations with differing guidelines on screening. But therefore, what we've done in the National Medical Association is have educational programs so that the doctors and other clinicians have the latest and the greatest information that is available.
Very necessary.
And
Wonderful.
Lisa and I have been doing that for, oh my goodness,
A long
decades.
time, we're still at it. And Edith, it's not just your legislators in Pennsylvania. You could pick up the phone and call any legislator. They know who you are. So thank you for lending your voice. If I could just make one other point.
Yes,
All of you women out there, if you have had a biopsy and were told that it was normal, benign, that's great, but please find out exactly what it showed, because sometimes those benign biopsies show that you're at higher risk for breast cancer in the future, and there are things that you can do to take care of yourself even better in that circumstance.
That's
Thank
where
you, Dr.
knowledge
Newman.
counts. That's where the knowledge is.
knowledge, absolutely. I mean, who wants to be ignorant of something that when the ignorance can cost you your life? I have one more quick question I'm going to squeeze in here from the Q&A. I'm going to try to combine it. One person asks, this idea of the ACR guidance for Black women getting a baseline risk assessment at 30. What does that mean? Is that a mammogram or what? The other one quickly is a woman who says, I'm a breast cancer survivor of 13 years and I have a 29-year-old daughter. When should she get a mammogram? So this is diving into something I know you're going to talk about more later, but give us kind of a sampling of what you guys think about this, Dr. Newman or Dr. Minchell.
So getting a baseline evaluation of your breast risk at a young age, at age 30, I think is very reasonable and appropriate. And that means knowing your family history, getting an idea if you have any hereditary predisposition for breast cancer, knowing whether having a good clinical breast exam, that is all critical, and learning about how to evaluate your breasts yourself. Definitely important. With regard to the question about family history of early onset breast cancer, the rule of thumb that we use is that if you have relatives diagnosed with breast cancer at young ages, the women in those families should start getting their own mammograms 5 to 10 years younger than the youngest age at breast cancer diagnosis.
Wonderful.
Correct.
And Dr. Mitchell,
Yes.
anything quick to add to that before we wrap up here?
Yes, and also in addition to the family history, it's important to look at other risk factors such as weight.
Yes.
Obese women have a much higher risk of breast cancer. And then finding out if there are preventive strategies that we can utilize. We've heard of the drug tamoxifen, for example, for treating breast cancer, but it's also a preventive measure in women with high risk. So it's not just getting a mammogram, it's looking at the other factors that may be related to family history, and not just family history, but the genomics of women who have had not only breast cancer, but other cancers such as pancreatic cancer, ovarian cancer, and others. So it's getting a lot of information to determine risk.
Well, thank you, Dr. Mitchell. Thank you, Karen Jackson. Thank you, Dr. Newman. This has been a wonderful discussion, authentic, informative, robust. We could have gone on for a while, but I look forward to seeing the upcoming presentations. And a reminder to attendees, folks who are listening in, check out the virtual exhibit areas that are part of today's event. You can download items in your digital swag bags. So I'll see you guys at the closing session. Thank you.